the doctor was recognized all thrombosis because organized thrombosis was suspected. 2 days later, surgical treatment was applied. Right side hemicolectomy was performed without any complications. Pathologists recognized adenocarcinoma of the second. Gastroenterologists initially recommended enoxaparin in prophylaxis dose for known right iliac vein thrombosis, but anticoagulation was not definitely applied because of the significant anemia and no clinical symptoms of thrombosis. 6 weeks later, in September, the patient was consulted by a clinical oncologist. His clinical functional status was improving, morphological results became significantly better, and the patient was qualified for adjuvant chemotherapy because of the high risk of recurrence of cancer. Lymph nodes were involved. For the next 6 months, the patient has been treated with chemotherapy, fluorouracil and leucovorin. He reported exercise intolerance and fatigue, but these symptoms were interpreted as a consequence of chemotherapy, and there were no hematological complications related to chemotherapy or other drugs, anti-cancer drugs. And 4 months later, the patient had control hospitalization. Colonoscopy ruled out recurrence of colon cancer, but blood count revealed polyglobulia with high level of hemoglobin and hematocrit. And the next patient's oncological visit confirmed no recurrence of cancer disease in colonoscopy and ultrasound examinations, but morphological results confirmed the increasing level of hemoglobin and hematocrit, and the patients reported exercise intolerance, which progressed from 2nd to 4th functional class. And next year, the control chest computed tomography confirmed pulmonary embolism. Left pulmonary artery at the level of bifurcation had visible loss of contrast enhancement, representing about 40% of vessel stenosis. Of course, anticoagulation was recommended. Next year, in control computer tomography found no significant difference compared to the previous test, but the radiologist found moderately enlarged heart. And despite continued anticoagulation, patient's clinical condition was not improving. Next year, 2012, lung scintigraphy confirmed the segmental pulmonary perfusion defects typical for pulmonary embolism. And in January 2013, the patient was admitted to our center, Department of Pulmonary Circulation and Thromboembolic Disease. And last year, we have discussed about the patients with arterial pulmonary hypertension related to dasatinib. That patient had the diagnosis of chronic myeloid. Everything is okay?
Yes, as far as you're concerned, yes.
Okay. So now we propose the discussion on patients with with diagnosis in group number 4 of pulmonary hypertension related to chronic thromboembolic events. And my chief, Professor Adam Torbicki, will continue the presentation.
I have to present the start of the case because our younger colleague who who was scheduled for this presentation because he was actually involved as an interventionist in the treatment of this case, is currently at the hemodynamic table doing a similar procedure. So I will try to replace him, and on the screen you should see now the CAT lab results of our patient from which was taken in January 2013. You can see that his mean pulmonary artery pressure was very high. It was 52, so it was almost three times as high as we would expect in a normal person, with normal wedge of 9, reduced cardiac index, and a very high pulmonary vascular resistance. On CT angio, he had mural thrombi in relatively distal arteries. Here with an arrow you can see one of the most proximal deposits of the organized thrombi, and on the next slices you see them in other smaller vessels. And you can also appreciate the domination of the right heart chambers, which are normal with the levels of pulmonary arterial pressure and with normal wedge. So this was definitely precapillary pulmonary hypertension with a significant, though relatively distal, post-thrombotic organized deposits. So as you can see at the bottom of this slide, after performing right heart cath, CT angio, and then also standard pulmonary angiography, which was already a part of treatment, so I will leave the discussion presentation of pulmonary angiography for slightly later, we decided to diagnose him as chronic thromboembolic pulmonary hypertension. And now let me present to you some of the most important issues related to this disease. I'm not quite sure how familiar you are with this type of consequences of acute pulmonary embolism. So I'll just briefly go through this topic, reminding you that after acute pulmonary embolism, you might have two major scenarios. One is complete resolution of thromboemboli, and sometimes it can be really beautifully seen on perfusion lung scintigraphy, or some post-thrombotic residua will persist over time and will remain forever. And if you look at the data that we have from the literature, the left panel shows you the fresh thrombi, which were causing venous thromboembolic disease moving from the veins to pulmonary arteries. On the right side, you see how an organized, extracted from the pulmonary artery thrombus or other organized tissue looks like. In general, at 1 year, you can expect some residual organized thrombi in from 15 to 50% of patients. But the key issue is not to find their presence, but to look at their hemodynamic consequences, because as you can see on this old graph taken from a paper from '82 when surgery was still not available for those patients, there is a dramatic relationship between the level of pulmonary arterial pressure and mortality. And if PAP exceeds 30 millimeters of mercury, then the disease becomes really a malignant disease with dramatic reduction of long-term survival.
Is this data mean pulmonary artery pressure or systolic pulmonary artery pressure?
All those data. This actually comes from a very good Czech center. There was a school of Professor Widimski in Prague it was a very renowned, even in the States, School of Pulmonary Circulation, and they did it, and it remained as a great contribution to our understanding of this type of disease, because all those patients had post-embolic residua, and they were catheterized. There was no treatment. Nobody knew how to deal with it. Anticoagulation did no benefit to them. And this is our starting point. And then also based on this Kaplan-Meier curves, you can see that we have a third scenario after acute PE. So we have post-thromboembolic residua without resting precapillary pulmonary hypertension, or with resting precapillary pulmonary hypertension, and this is called chronic thromboembolic pulmonary hypertension. Luckily, this red box represents, in fact, very few patients, because if you look again at the series that has been published, the largest, which are about 800 patients, followed after acute PE, show that about 1% of patients would be expected to develop chronic thromboembolic pulmonary hypertension after an acute pulmonary embolism episode. So this is a rare disease, but as you could see on the Kaplan-Meier curves, very, very severe in case PAP is increased significantly. Now, why we are talking about it today? Because out of a whole list of risk factors for chronic thromboembolic pulmonary hypertension, of which probably the key issues to start with are large clots that have been in the pulmonary arteries during an acute episode, and also a significant afterload increase for the right ventricle. So it has to be a relatively large, severe pulmonary embolic episode. But among other risk factors, you can also find cancer, and this is why we are dealing with it today. Maybe even more than this review paper from Professor Goldhaber, it is maybe more interesting to look at the paper which focused and brought some data to our knowledge from Vienna, and you can see here that a history of malignant disease was observed in about 12% of patients with CTPH, when compared to about 5% in patients with other precapillary forms of pulmonary hypertension. And you see here the list of cancers which were found in this study. The study was about 1,000 patients from several European centers. It was mainly breast cancer, gastrointestinal carcinoma, melanoma, prostate cancer, and seminoma. And interestingly, the time interval between the diagnosis of cancer and the development of symptomatic CTPH was in the order of 5 to 10 years. Why it is like this, probably Sebastian already mentioned a little bit about it. First of all, patients with cancer rarely get a very aggressive reperfusion therapy, such as thrombolysis or surgery. So in this score, which has been recently developed by our Dutch colleagues, you can see that thrombolytic therapy is a protective factor. While diagnosis delay is a factor favoring development of chronic thromboembolic pulmonary hypertension. And this is true for cancer. Usually in cancer patients, the diagnosis is more delayed than in overall population, and they very rarely, because of the risk of bleeding, receive thrombolytic therapy or are submitted to surgery. Now,
why would diabetes be protective?
That's a very good question. Nobody knows, but I must say that this is the second paper independently pointing at diabetes as a preventing factor, and when it was first time announced, everybody saw that it is a kind of outlier or an error or a statistical joke. But here it is the second time when we see it. So it might be an area of some research. We in fact don't know why those patients do not lyse their thrombi, why they do not clear their vessels, because you cannot put all the blame on our insufficient therapy. Sometimes we don't know. And there were theories that there is a different type of fibrinogen, and it is a genetic problem. This is still a matter of debate. We know better how to treat those patients than we understand the really background of the disease. But diabetes mellitus, I'm happy that you follow our presentation because it is an excellent question to ask. We don't know, but it is here. So now what to do with those patients? If somebody has chronic thromboembolic pulmonary hypertension, the main treatment strategy is to try to perform a true end arterectomy of pulmonary arteries. This is a very tedious and a very difficult surgery, one of the most difficult cardiac surgical operations that exist. There are only about 20 centers in the world that are doing it well. One of the best, or maybe the best, is San Diego, California, where they have, I think, more than 2,500 patients operated with this disease. But there are also other good centers all around the world. So you have to separate intima together with the adjacent organized thrombus and take it out like a glove from the right and left pulmonary artery. And the most striking example of such an operation, here you can see this this part of intima which is being removed by our cardiac surgeon. This is from our Warsaw cardiac surgical team, Professor Biederman. And here you can see how it can look like after removal of the deposits inside the vascular lumen. This comes from Walter Klepetko from the University of Vienna, also very experienced PE surgeons, as they are called, because it is pulmonary and arterectomy PE surgeons. And you can see how dramatic the hemodynamic improvement might be. The baseline PAP was 67 here, and it dropped to 18, and 1,200 dynes dropped to 220 dynes. So this really puts the patient on a normal Kaplan-Meier survival curve and brings him to a normal life expectancy and quality of life if surgery is possible, if the changes are not too distal, and the pressure can be brought down. Not all the patients with CTPH, unfortunately, have this type of changes, and you see here a classification coming from San Diego. Some of those changes, types of those changes, result in higher mortality after the operation and lower chance of bringing PVR to closer to normal values. So in a large registry, European registry published in Circulation 4 years ago, you can see here the best PE surgeons of the world, which gathered in Zurich. In fact, I was the leading force of this photo. I brought them together and said, well, why don't you take your photo once so that everybody knows how you look like? They could, in this registry, they could only operate about 55% of patients. Half of the patients are non-operable because either the two distal lesions or they have too high risk of the operation, which takes many hours, and it is in intermittent deep hypothermia. It needs to cool the patient down to 18 degrees. And there is a dramatic difference between the life expectancy of the patients that could be operated and couldn't be operated, despite the fact that those two groups are very similar in terms of hemodynamics, as you can see here in this box in the middle of the screen. So this is a bad luck to have distal disease and to be disqualified by the PE surgeon from this type of intervention, because you can see how dramatic the follow-up survival looks like in the blue line, not operated the patient. Another paper from Vienna again found that the history of cancer, in addition to be more frequent in patients with history of cancer increases the risk of CTPH, but also history of cancer were more frequently found in the non-operable group. So for some reasons, those patients are not good candidates for surgery. As you can see, there was the difference of 10% of CTPH of cancer in operable and 16 or almost 17% of patients with history of cancer in the non-operable CTPH patients. So now let's get back to our case, and you can see that between January 2013 and January 2015, this patient was progressively increasing his pulmonary arterial pressure based here on the tricuspid jet velocity measurement. So this is something closer to systolic pulmonary arterial pressure. However, he was also moving down to the more dramatic survival curves. We were waiting for some time because we were not ready with any alternative treatment, and this patient has been disqualified from surgery because of relatively distal lesions and some renal insufficiency, and also partly because the history of cancer was also considered, especially with this lymph node changes, a potential limiting factor for the surgeon. So we decided at that time to use this new method, which we are trying today to present to you, which is abbreviated as BPA, which is balloon pulmonary angioplasty, and you can see it already in the ESC guidelines published this year in September, that if the patient has chronic thromboembolic pulmonary hypertension, but he or she is technically non-operable, we should be considered for BPA in an expert center. This is also very important because the experience with this technique is very, very limited, much more limited than with surgical treatment. So now I hope these videos will move. And this is pulmonary angiography of our patient. It is almost anteroposterior, and this is lateral view. You can see here that the changes are there. There are webs which limit kind of resistors that limit the flow to the lower part of this pulmonary arterial bed. There is also very little flow to the upper lobe. Here also to the middle lobe. This artery is very narrow. The flow is very poor. So there are many distal occlusions and resistors which bring this pulmonary vascular resistance to such a high levels. Now this is the right side. I hope it will run also. And this is a similar problem, also a large defect in perfusion. Here you see a very narrow orifice of those vessels which should supply all this part of the lung. So there are many distal things here again to the middle lobe, very dramatic changes. What can be done in these cases? On the left you see pre-angioplasty images, and look here how the vessels reappear after angioplasty with this distal tree of small vessels, and with a very good, usually very good flow to the veins and to the left atrium, which is very reassuring for us always. I'll try to move it once more, or maybe we'll go to another. We have got small problem.
So how do they only do an angioplasty? They don't put any kind of residual stent in there?
No, because it seems that this is not the because this is not a type of disease which results in restenosis. So once you get rid of the webs and bands that are inside the pulmonary arteries, if there is some elastic recoil, it's an early recoil. You can get rid of it by performing a second angioplasty, but there is no need to put a stent. Nobody really did it, but the experience from Japanese centers, which is by far the largest in the world, because they started relatively early, shows that there is no recurrence of pulmonary hypertension, and that there is no need to protect these vessels from restenosis.
And then
I'm afraid you cannot. Can you see our screen?
Yeah, we can still see your screen.
A lot of chaos on the screen, yes. So
well,
that's good because it
I
means
I wanted to learn some Polish today, so I
but
did.
I hope that we'll be ready with. Can you see our slides? Yes.
Yeah. Yes.
Okay. Wait, I'll go back to this last video. Videos are very dangerous. So this is again, left side is before angioplasty, and the right side will be after angioplasty. And you see here completely new vessels that reappear after balloon angioplasty. But this is, of course, just angiographic picture. Why you can also appreciate the changes of the lumen of the vessel with intravascular ultrasound. But the most important thing is why, when you look at the hemodynamics after this angioplasty interventions, and you can see here that, for example, in this patient, already after the first procedure, which is not very typical because usually you need 4 to 5 procedures to get a significant hemodynamic result, but also here after the first shot, he decreased his pulmonary arterial pressure from 52 to 37 and normalized his right atrial pressure, which is a sign of good compensation of the right heart. A couple of days ago, he had a second session, and we will probably have another 1 or 2, but we wanted to show you this because this was, in fact, only 1 of 2 our cancer patients that so far were submitted to this procedure. So our experience in Otwock in Poland is now about 100 BPA procedures. At the time of October, it was still about 80. And as you can see here, out of this 32 patients altogether, we had 3 deaths. And this was, of course, a kind of problem. We are slightly, despite this very steep curves that we would like to combat, we were not very happy with periprocedural mortality of 9%. But when we looked at our initial data when we started in Poland the pulmonary endarterectomy program, this was exactly the same. We had 9% of early mortality, and now we have 2%. And in fact, even now, when we compared the rate of complications and also mortality for the first 40 procedures compared to the next 40 procedures, there is dramatic reduction in complication rates. So the learning curve here is of utmost importance, and we hope that there will be no more deaths, or if there will be, there will be very, very few. Now here are the hemodynamic results counted for 23 patients that had at least 3 sessions of balloon angioplasty, because you have to go from one lung to another lung, from segment to segment. And maybe you should look at the middle part. This is a reduction of pressure. Also on the left side, you see normalization of right atrial pressure, reduction of pulmonary vascular resistance on the right side. Dramatic fall of NT-proBNP. I must say that this is also very reassuring. Now, if you are interested who did it, there's also, of course, improvement in functional class. I will not go into details because we are slightly running out of time, and probably you would like to ask some questions. So I'll move to the history, and the first case was described as far as in 1988. It was from Netherlands. Nobody really looked at it, and then this was exactly with the same results as we are seeing now. And this was published in Chest in '88, as I already mentioned. Then there was about 12
So
to 15.
how do you determine how much to take on in a given setting? So like when we do infarct angioplasty or stenting, you know, the long-held dogma was only deal with the infarct vessel, and then, you know, recently people have been, you know, getting a little greedy and go and deal with some other stenosis if things go well during the infarct angioplasty or stenting. So how do they, in the case of these, if you're going to do one segment and it goes well, do you just call it a day and come back the next time and do a different segment?
Well, there are 2 limitations. Initially, it was thought that maybe not too many vessels should be approached because of risk of more extensive reperfusion edema, which may happen after this type of procedures. And then it may deteriorate the patient in terms of respiratory function. We also had this problem, and everybody has this problem. If you dilate too much, you may have an extensive reperfusion edema with respiratory failure. Now this problem is maybe slightly less important, but the limitation is radiation. It takes quite a long time to navigate inside the pulmonary arterial bed, and also the amount of contrast. Those patients, in fact, have, during this procedure, which usually lasts about 2 hours, they have several selective, but still significant in terms of amount of contrast injections. So there are some rules which are followed in order to limit the radiation and also limit the amount of contrast, volume of contrast, in order not to damage the kidneys. So this would be probably an issue. Also, I must say that those interventions are quite tiresome, and so the team that's performing it can deal with at most 2 to 3 patients per day, and it takes quite a long time to do this. So the hemodynamic lab is also occupied for the whole period. For example, today we have in our hemodynamic lab two balloon angioplasties, but they are separated by coronary angios because we have some relatively urgent but not acute coronary syndrome patients. So we have to share this, and this is also some limitation. But mostly the amount of contrast and radiation. Okay, can I go on?
Yes.
So after about 12 years, there was a very interesting paper from Brigham and Woman by the group of Sam Goldhaber, which reported on 18 cases. This was the first series, but it has been torpedoed by the surgeons. They said that it is impossible that this can be effective because what they extract from the pulmonary arteries is so stiff that no balloon can deal with it. And in fact, there were 2 deaths in the series, so relatively high mortality. And also, they never repeated or extended their experience. So everybody thought that maybe there is something wrong with this and this procedure, and it was lying unused for another 10 years, and Japanese centers took on. And at the beginning, we didn't believe them, but afterwards, it turned out that they are right. And as you can see on this map, this is a map of Europe and Japan experience, and you see that the most experienced center in Okayama in Japan reports on 1,700 procedures, and this is true, and everybody from Europe are visiting now the 3 Japanese centers to learn from them, and in fact, they do it very well, and we were able to reduce our rate of complications after visiting our leader of this project, Professor Kuzhina, who visited them after some time of gaining his own experience, and he came back with much safer and more effective strategies, and this is really very helpful. So you see here the leading centers. There's again University of Vienna with Irene Lang, our center, Oslo University with Arne Andreasen, Hanover with Marius Hopper, Bad Neuheim with Professor Meyer, and then 2 centers in France, Gérard Simoneau and Hélène Buvet in Grenoble and in Paris. And this is why, as I mentioned already, BPA entered the guidelines. It has still a relatively low 2B class of recommendation, which is may be considered, but it is already in the treatment algorithm. And in our conclusions with Sebastian are that 3 simple conclusions: that malignancy seems to increase the risk of non-operable chronic thromboembolic pulmonary hypertension, so this might be something interesting for balloon angioplasty. Symptomatic CTPH may emerge long after cancer has been cured, and the balloon angioplasty may represent a new therapeutic options for CTPH in patients not suitable for surgery, and this may include some patients with history or with history of cancer or with active cancer, because this would be even more difficult to treat with surgery. But here we don't have experience. So of course this is a very preliminary report, but since we want to be more a little bit exotic, we decided that we should tell you about it.
It's fantastic. What an unbelievable presentation. But I still wonder, the newer anticoagulants, would they be any better at preventing the progression of thromboembolic disease? I don't know. And then the other question is, would statins have any bearing on this? Because you kind of have this diffuse, rind of thrombosis that is occurring, and that's what surgeons are cutting out of there. Is, like you said, it's like a glove. Could some effect of statins, for instance, to decrease inflammatory response, might that be helpful in those patients? I mean, I don't know.
This is a good question, because statins are obviously working on everything, but there is no data, absolutely no data on this. And probably the issue is not that much in the vessel wall in terms of inflammation, though inflammation is also listed among potential contributors to this type of process. Probably the most important issue is fibrinogen, because sometimes the patients, even treated in an optimal way, still develop this type of consequences, post-embolic consequences. But we are learning about this disease more and more because of the increasing awareness of general medical profession with regard to this disease. We have also a large European registry, and not only European, because also colleagues from San Diego are contributing to it, and there are meetings of the task force which tries to find some explanations and also try to look for potential new treatment strategies. But not answering to your question, I wouldn't bet on NOACs would be any better compared to the old drugs in prevention of this type of consequences.
And then what does the pathology show when you take these things out and you look at them? What is it, just thrombus? Or?
No, it's a connective tissue, actually. It's fibroblasts, and connective tissue. It's just like a scar.
Fascinating. It was a really amazing presentation. Eric, do you have any comments?
We are open. We are open to questions.
Eric, what do you think about all that?
Yeah, that's a terrific presentation. I applaud the group from Poland and appreciate the presentation very much. Does this occur also more frequently in connective tissue disease?
Maybe I didn't catch the question, whether it is connective tissue disease?
Yeah, is it sometimes part of the sequelae of scleroderma or connective tissue disease, since you see that connective tissue that you're basically excising?
No. This has nothing to do, though there is some increased risk relating to antiphospholipid syndrome, but otherwise there is no, most of the patients do not have connective tissue disease which develop this type of changes. So this is not the key factor.
And
then we
guys...
have there's a new approved drug, basically a DEMPAS, approved by the FDA. That's a nitric oxide cyclic GMP pathway pulmonary vasodilator that's been approved for these treatments. Do you have any experience with using that on the unoperated patients?
Yes, this is a very good question. We didn't want to complicate this presentation by going into the details of pathophysiology of progression of this disease. But once you ask this question, I can say a few words. We were in fact involved in this research, which led to approval of this drug. But I would like to start with the concept first. When you saw this dramatic Kaplan-Meier curves, they are very similar to the ones that you can see in pulmonary arterial hypertension if it is left untreated. And the truth is that the progression of the chronic thromboembolic pulmonary hypertension is not due to recurrences of pulmonary embolism, because all those patients, once diagnosed, they are put on anticoagulants, and those anticoagulants do not stop the progression of the disease. Why? Most probably because when you have a a certain percentage of the pulmonary arterial bed occluded, the whole blood is distributed under increased pressure and flow to the remaining still patterned pulmonary arteries. And this is just like in congenital heart disease. This kind of shunt redistribution damages those small arteries and induces similar changes as those that lead to Eisenmenger syndrome. So to protect these vessels, there was an idea to use the drugs which are useful in pulmonary arterial hypertension. And in fact, riociguat, Adempas, which it is called in Europe Adempas, is the first drug that has met predefined endpoints in a large randomized controlled trial and has been approved for this indication. So it is indicated for non-operable patients with CTPH, and in a way probably will be a second alternative or adjunctive to balloon angioplasty. So we'll have two possibilities. And in fact, if you looked at the guidelines, I will try to go back to this scheme. You can see here medical therapy as one of the options for this non-operable patients. And this is exactly riociguat approved, as you mentioned, for this indication.
So I think we're going to be a participating site, patients that develop an acute PE, and we do some lysine catheter procedure where you go and lyse the thrombus. Do you believe in that technology, or do you think that that's of any value in the acute management of PEs that are large?
Well, this is again a big area of controversy, and if you look at the relatively recent data which show that in fact thrombolysis is protective against chronic thromboembolic pulmonary hypertension, so then this type of intervention that you mentioned, they are also sometimes related to ultrasound application through a catheter which has also ultrasound crystals and make the clot more prone to intrapulmonary thrombolysis or manipulations. Then it would maybe suggest that this is a good strategy. On the other hand, please remember that only about 1 to 2% of patients will ultimately develop CTPH. So we still don't know where to put criteria for more aggressive treatment of massive, anatomically more massive clots during the acute case of pulmonary embolism. This is an open question. We still don't know many things, and this is one of those things that we really don't know exactly how to handle. At the present, however, in PE guidelines, the position of interventional treatment is relatively low, especially in Europe. In the United States, it is on the same level as surgical embolectomy. In Europe, we are still more cautious, and it is a 2B indication for acute PE.
Yeah. No, this has been a truly fantastic presentation. Thank you so much. Really great.
So Dan,
thank you very much.
Dan,
Thank you. We would like. Yes, Eric?
Yeah, we did have a case of a gentleman who came in shock with massive pulmonary emboli, and we couldn't take him to open heart surgery, and we couldn't take him to interventional where you put in thrombolysis and then you put a catheter in, like a pigtail catheter, and you try to stir it around. And so this was a patient that was in shock, and we put he had a low heart rate, so we put the Zoe on and we paced his diaphragm and his chest as well as his heart. We turned it up all the way, and we gave him thrombolysis, gave him TPA, and basically all of a sudden his clot became somewhat lysed, and his he was cyanotic, and he pinked up, and his heart rate and blood pressure came up, and he looked really good. And so we wrote that up, and it was called Thrombolysis Cocktail, Shaken but Not Stirred.
That would be a fairly extraordinary case.
I must tell you that my immatriculation plaque in my car is 007, so I'm all for
it. Wonderful. I'm glad to hear that. So thank you so much for your presentation. It was brilliant, and we have a recording that we will post online at the website. We really appreciate this in detail analysis of something that's fairly esoteric but can be revolutionary for a few people in terms of treatment. So thank you very much. And Dan, I appreciate your questions and comments as well.
Super. Thank you guys so much.
We'll see you next week.
Thank you very much for your attention, and we would like to show you that cardio-oncologists should remember about late complications related to thromboembolic events. Thank you.
Exactly, and we're all looking forward to Vancouver 2016, September 29th and 30th.
Yes.
Thank you.
All righty. Sounds
Christmas. Good. Have a wonderful Christmas time.
You too. Thank you so much.
This would be a good presentation for Vancouver, Dan.
Oh, yeah, definitely.
Be great. Thank you. Bye-bye.
Goodbye.
Bye.